EquiCOG. The COG stands for Cranio-Oculography. Is this the same as VNG? No, this is much bigger advancement over VNG. That is why it needs a separate name, Cranio-Oculography. Is it just a technological advantage, or does it also include a clinical relevance? It includes both. It's a huge technological leap, and it is also clinically very much relevant. In the last 10 years that I have been helping people interpret videos or interpret graphs that are coming from video nystagmography systems, the problem that I used to face was this. The video has an eye oscillation pattern called nystagmus. The graph also shows an eye oscillation pattern called nystagmus. Nystagmus by itself does not mean normal or abnormal, because when the individual is actually moving the head at that particular point of time, nystagmus that appears could be physiological. So if it is physiological, if you take that nystagmus as pathological, then we lead to wrong interpretations. So that should not happen. So the best way of preventing that is providing the context of what was happening to the head at that particular point of time when the eye is also being recorded. Therefore, we made this addition to this tool, which is along with the eye movement recording, we also record the head movement. Now, this recording appears in the videos of the eye movement along with the head movement, and also the head velocity tracings show up along with the eye tracings. So the eye tracings come with head velocity tracings. So you can see the tracings take the context of the head movement. Even in the video, you can see the head movement. Now what this does is, this removes all guesswork that is related to whether the head was moving what, and therefore this nystagmus came, which is considered the per positioning nystagmus, not the post positioning nystagmus. The per positioning nystagmus is physiological. It does not mean disease. Post positioning, which is after the head position has changed, when that nystagmus comes, that is pathological, and whether this particular individual has that or not, pathological nystagmus or not, can only be with certainty ascertained only when you have context of the head movement. That is why we added the head movement, both the graph in the tracings of the head velocity and also of the video of the head movement exact position. The other advantage of this one is, what exact, in benign paroxysmal positional vertigo, what exact head position was the person taken into, that also is there. The second thing here is whether the relevant position was actually achieved during the testing or not. We can always look at the video and find out whether that particular position was achieved or not achieved. These are many advantages that are there. In addition to this, the other problem that we see is there are certain places where there is a stroke that is happening in the brainstem. So if something like that is happening and that has caused the vertigo in that particular individual, in that case, the size of the pupil becomes very important, because we see what is called as a Horner syndrome in a person who presents with recent onset or acute onset vertigo with spinning sensation with a Horner's, or with the pupillary size being less or small, then that actually means a problem. So we need to actually look at the pupil size also. So what we decided is technology should allow pupil size assessment as well. So we included pupillometry. When we were adding the pupillometry, then we added all the relevant parameters into the pupillometry, like afferent pupillary response, stimulating one eye and studying the response in both eyes, stimulating the other eye and studying the response in both eyes. And then the other beautiful thing that is being demonstrated right now, we hardly had signs related to migraine in eye movement so far. We were trying to see whether there are abnormalities in saccades, whether there are abnormalities in pursuit. We used to get a certain type of abnormalities in pursuit, but we were really looking for a bigger marker. Now, there is an emerging marker that is showing in the pupillary oscillation that happens in constant low light illumination. So we have added that protocol into that is the HIPPUS protocol. So what used to be done with video nystagmography is being done. In addition to that, there is much more that is being done. In addition, this video nystagmography is a very generic term, and then single eye recording at 25 samples per second or 30 samples per second, that has been happening. Very dated products, that are there for many decades ago, that is also called video nystagmography. Binocular systems also are called video nystagmography. Everything, irrespective of the frame rate, irrespective of the number of eyes, whether monocular or binocular, everything is used to be called video nystagmography. We need to differentiate a technology which is much better, which is clinically more relevant, which gives much more information compared to the rest of them. So we need a different term and different product to differentiate this, so that both the clinician and the patient knows that their results are now much more reliable, because the context of head movement is there. Also, their pupillometry is being studied. The next advantage of this particular device, the EquiCOG device made by Equidor, is that each eye is recorded at 100 samples per second at very high resolution. At 100 samples per second with a very, very good resolution, it happens that you can do a slow motion playback, and the slow motion playback allows you to see certain types of nystagmus with more clarity. What need not show up at the actual speed will show up much better at the slow motion playback speed. In addition to the eye position tracing, which is traditionally available in a lot of VNG systems, we have the eye velocity tracings also available. With just one pop-up, they can click and then see the eye velocity tracings at different times. Now, what else is possible with EquiCOG? Now, there is one particular test called the head impulse test. Clinically, we do the head impulse test. We move the head and see the eye movement, which happens compensatorily. Like the head is moving to the right, the eye has to move to the left. In real time, we study that. We can use our mobile phones, everything. Or we can use our naked eye examination. All of these things we are able to do. But when we do that, generally clinical head impulse test is limited to checking the horizontal canal, the right and the left horizontal canal. We are not able to, in the clinic, assess all the 6 semicircular canals. Now we can have a dedicated video head impulse test or a dedicated functional head impulse test to study each of the individual semicircular canals, or we can just use the same cranio-oculography system, run a protocol where you do exactly like the clinical head impulse test, open the video frenzel mode and do the head impulse test. You have the head movement recording, you have the eye movement recording in the video. Just compare whether the eye movement and head movement has been happening simultaneously and compensatorily in opposite directions. If that is happening, that particular canal is working, and you can do this for all the 6 canals. You can do all the 6 canals in a video frenzel mode of the cranio-oculography system. You also get the tracings. So the tracing, even in the video, if it takes, it's not that easy to see and compare on the graph with a line marker. You can easily compare whether events are happening at the same time or not at the same time. So the tracings are also available. We can do all of these things. That is why this one particular tool called cranio-oculography is 100 samples each eye recording of the eye, along with rendering of the head movement, not just video rendering of the head movement, but also rendering of the head velocity. In addition to the head velocity, the head rotations in the yaw, pitch and roll planes is also shown. Then in addition to that, we have a pupillometry protocol. Then we have the ability to perform a 6-canal head impulse test on one of the video frenzel modes on the same system. And then the same system also provides you a tool to do a clinical chair rotation test. A clinical chair rotation test without the need for motorized chairs. You can use a clinical chair and do the chair rotation test, do the vestibular reflex suppression test, which is a test for the cerebellar flocculus. All of these things are possible in one tool. So when you're doing a clinical chair rotation test using the same device, you're doing the standard ocular motor test using the same device, you're doing a pupillometry using the same device, you are recording head velocity at every point of time using the same device. Like look at even saccades for that matter. There are some patients, like for example a person with Huntington's, what happens to them is they do some saccades which are either blinks initiated or head movement initiated. Now, having the head velocity tracing will ensure that even in the saccade test, if the saccade has been head movement initiated, that particular head velocity peak is going to be seen. So it is so important that we have a head velocity tracing and head velocity or the head position or head movement video along with the eye movement. So both of these things really add value. So this makes cranio-oculography a totally different product and a new age product, and it deserves a separate name, and we need to differentiate it from the traditional video nystagmography system. To conclude, I can just tell in one word or in one sentence, VNG is old, EquiCOG is the future.